The genus Haemophilus are gram-negative rods. They're relatively small and they are facultative anaerobes, which hopefully you remember from Bio 120 means that they prefer oxygen or they grow well in oxygen, but they can also grow without oxygen, so they can do both. There are a number of different organisms and genera that kind of fit in the same classification, but we're really only going to talk about Haemophilus because it's the most common that you would see in a clinical setting. Members of the genus are found typically on the mucous membranes. They do require the hemin and NAD for in vitro growth, which is why we'll most often grow them on chocolate agar. And that's what they're showing you here. The most common species of Haemophilus is Haemophilus influenzae, and they grow as these smooth, kind of grayish colonies on chocolate agar. Haemophilus influenzae, like I said, is the most common species that we see in human infection. It has a polysaccharide capsule and 6 different serotypes. Type B, Haemophilus influenza type B, is the most dangerous and implicated in approximately 95% of invasive infections. Unencapsulated Haemophilus influenzae and another species, parainfluenzae, are normal members of the microbiome that colonize the respiratory tract within the first few months of life. So remember, we're more worried about encapsulated Haemophilus influenzae because capsules are helpful for avoiding the immune system, allowing for more invasive infections. However, even these species that are part of the normal microbiome can cause things like middle ear infections, sinus infections, and lower respiratory infections. But like I mentioned, the encapsulated strains are more common causes of severe disease, particularly in unvaccinated children. And so that's a trend we're going to see for the rest of the semester. Unvaccinated children tend to get disease at higher levels than vaccinated children, and the disease tends to be more severe. Who would have thought? Now, the common manifestation of disseminated or invasive Haemophilus influenza is going to be something like meningitis. What we'll tend to see in the patients is a 1 to 3 day history of a mild upper respiratory infection before the symptoms of meningitis, fever, headache, stiff neck. And even with treatment, mortality is still about 10%. So this is one of those areas where, again, you can include it in your reflection if you want, but you definitely need to be thinking about it as you're preparing for your exam. How many of the bacteria we've talked about can cause meningitis? Probably a lot. And I've shown you that mortality is high even with treatment. Mortality can be very rapid, as we saw with Neisseria meningitis, even with treatment. So what you need to think about in order to think about these infections like a clinician is how could you rapidly, you don't have time for, weeks of serology, nucleic acid testing, you may not even have time to do culture. How can you rapidly distinguish between the different types of bacterial meningitis to be able to diagnose the infection? So that's something you as the clinician and the student in this class need to think about. So do not think about these organisms as isolated organisms. Think about the types of disease. Okay, well, what causes meningitis? What causes diarrhea? What causes a rash? How do you differentiate those things? Haemophilus influenzae is also one of those bacteria that is highly implicated in causing epiglottitis or inflammation and infection of the epiglottis. So that infection, that cellulitis, and the swelling of the epiglottis can block airways. And that's what we're seeing here. This is like a normal epiglottis, and you can see the opening to the airway, and then here it's all swollen and blocked off, and this patient actually has a tube to help them breathe. When you have especially a pediatric patient with epiglottitis and you need to intubate them, you usually only get 1 chance. So it is critical that you can diagnose these infections, recognize them quickly, and rapidly treat your patients. The bacterium can also cause cellulitis in the face. So you see this pediatric patient has an involved skin infection in their face and can cause juvenile arthritis in a single large joint. Here's a case study describing a patient who is older, 61-year-old woman with pneumonia caused by Haemophilus influenza type D, long history of smoking, chronic obstructive lung disease, diabetes, congestive heart failure. So this is a patient who is maybe not taking care of themselves as well as you would like, especially with the smoking. Some of the other things, can't be helped. You can't help if you get diabetes. But the smoking probably led to the lung disease, which could have led to the heart failure. So that's a challenge. She presented with upper lobe pneumonia, producing a purulent sputum with lots of gram-negative coccobacilli. So they're short rods. They're kind of in between a coccus shape and a true bacillus shape. Sputum and blood were positive for Haemophilus influenza type D, was susceptible to ampicillin, to which the patient responded. This case illustrates the susceptibility of patients with chronic underlying pulmonary disease to infections with non-type B strains of Haemophilus influenza. Remember, type B is the most dangerous. But because this patient was already compromised, she was at risk from some of the other types, like type D. As with most infections, the adhesins of Haemophilus help to mediate colonization, and some of their cell wall components, like the endotoxin of the LPS, can damage the epithelium, which can allow the bacteria to move into the blood. For the strains that have a capsule, the capsule is antiphagocytic, which is pretty common. Most capsules are antiphagocytic, which allows the bacterium to persist because it can avoid the immune system. And of course, the endotoxin also induces inflammation, and this bacterium can produce IgA proteases to interfere with humoral immunity. So again, that's something to think about. This bacterium can destroy the type of antibody that's supposed to protect the patient's respiratory tract. The more dangerous serotype, Haemophilus influenza type B, was relatively common in children before vaccination, over 20,000 cases per year in children under the age of 5. Since the introduction of the vaccine, the most recent data I could find, there were only 19 cases of Haemophilus influenza type B, which is sometimes abbreviated HIB or HIB, in the US in 2020. Worldwide, there were an estimated 3 million cases of Haemophilus influenza type B that caused 700,000 deaths. So this is a really dangerous infection, which is why scientists did their best to develop a vaccine. Because of the vaccine and because it's so effective at reducing the numbers of Haemophilus influenza type B cases, we now see that other strains of Haemophilus influenza, other types, and also non-influenza type infections are becoming more common. So some of the other species of Haemophilus. Basically, we got rid of Haemophilus influenza type B. That allows the other types and other Haemophilus species to kind of take over and be not necessarily more common. It's not like more people are getting infections. It's just that the people that are getting infections are getting different strains or different species. Some of the other species are listed here. Aegyptus, which can cause conjunctivitis, like the eye infection, Ducari, which can cause genital ulcers. And again, type B was a very important cause of disease in the US prior to vaccination. And then what they're showing you in this image are some of the different manifestations of disease and how often you would get a positive culture result. So for example, meningitis, between 50 and 95% of patients will have a positive culture from the cerebrospinal fluid and the blood. Patients who have conjunctivitis, 50 to 75%, you'll be able to culture out of the eye. but less than 10% from the blood. For patients who have epiglottitis, 90 to 95% of them will have a positive blood culture. They do not recommend you try to culture the epiglottis, right? Because you'd have to swab it, which can cause it to swell more. So, these are things to think about if you're trying to do culture. Where are you most likely to get a positive culture sample? The bacterium is fairly easy to grow as long as you're using the appropriate media. Again, chocolate agar or other media that's supplemented with the factors it needs, which include hemin and NAD. The gram stain of the cerebrospinal fluid can be diagnostic in meningitis. So think about why. What is this going to look like on a gram stain? What is Neisseria meningitis going to look like on a gram stain? What is Streptococcus pneumoniae going to look like on a gram stain? What is Listeria going to look like on a gram stain? So think about all of those things as you are studying this material. Again, you've got to make those connections. You can also do antigen detection of the polysaccharide capsule if you're trying to really get at what serotype the patient has. But when you're talking about meningitis, you've got to usually act more quickly than that. Because for patients who have untreated meningitis or epiglottitis, you have a mortality rate near 100%. So you have to rapidly diagnose and begin therapy in order to save your patient's life. Cephalosporins, amoxicillin, erythromycin can be used for various Haemophilus infections. We don't see a ton of antibiotic resistance yet in this genus, often because infections are less and less common because we have vaccination against the most serious form of disease. So if you look at your vaccine records, or if you've had children and you look at their vaccine records, you might see that they have the HIB vaccine, and that is the protection against Haemophilus influenza type B.